Hello, this is Sudharshan, and in this episode, chapter 43, we will talk about some miscellaneous bacterial infections of the GI system. First, starting with Campylobacter species. Mainly, we have this Campylobacter Jejuni. So, this is an organism, as the name suggests, it is spiral and corkscrew shape, which will affect the jejunum. And with the mode of transmission, it is the fecal-oral route and also from the undercooked food products like the poultry and dairy products. Rarely, maybe oral and sexual contact will be there. And with respect to the features, it is a gram-negative, motile, non-sporing and microaerophilic. And also it will be catalase and oxidase positive. And with the pathogenesis, if we see, mainly it produces certain toxins like enterotoxin and cytotoxin. So enterotoxin, it's a harmful substance that will destroy the intestinal cells. It is heat labile. And then cytotoxin, it will destroy the cells. Yeah, it will basically disturb the cellular organization, just like what Clostridium difficile does. And then with respect to clinical features, mainly GI distress, nausea, vomiting, abdominal pain, diarrhea, fever, infections, all this will occur. And also certain complications like Guillain-Barré syndrome, very common, where it causes ascending paralysis, central nerves mainly will be affected. And apart from that, the Reiter syndrome, rheumatoid arthritis, inflammatory bowel disease, all this can occur. With respect to the diagnosis, on gram staining, we can see gram-negative bacilli, which is corkscrew shaped, and darting motility, so it moves very fast, and certain culture media can be done. There are three important selective media: Skirro, Butzler, Butzler and Campylobacter. Transport medium is Kerry-Blair, and culture can be done as well. And then automated techniques, Malditoff-Vitek, ELISA, PCR. With the treatment, it would be supportive care, putting the patient on IV fluids mainly, antibiotic therapy, mainly this macrolides can be given like azithromycin or erythromycin. Sometimes tetracyclines and fluoroquinolones are also administered. Next, with Helicobacter infections, it is caused by Helicobacter Pylori. So it is a gram-negative bacilli, which is a rod shape, and it is helical, hence the name. So mainly it invades the pylorus of the stomach, and very important, Helicobacter pylori is the #1 cause for gastric carcinoma. And also it is catalase and oxidase positive, and also urease positive. It generates urease enzyme that breaks down urea into ammonia. Right. And with respect to the pathogenesis, mainly it secretes two toxins, VAC-A, VACA, and then CAG-A, that is CAGA. So VAC-A is vacuolating cytotoxin A. It harms the cells and forms holes in the fluid material of the cell, vacuoles in the cytoplasm. Then cytotoxin associated gene. Again, it will basically deform the cell. The cytoskeleton will be damaged. There will be the chance of the tumors will also be there. Release of cytokines from those tumors. Molecular mimicry occurs. That is, the host cell is confused between the self and non-self. It will mix up the antigens basically. And then, yes, so the risk factor mainly is smoking, and also those who are of A blood group, they are at risk. With respect to clinical features, GI distress will be there, and it causes different gastric conditions like gastritis, gastric carcinoma, peptic ulcer disease. Then apart from that, pernicious anemia and maltoma, that is mucosa associated lymphoid tissue cancer. And also it causes other conditions like GERD, Barrett esophagus, etc. So with the diagnosis, gram staining is done where we see gram-negative bacilli, which looks like a seagull. Culture is there like Scirrhos medium or chocolate agar, molecular techniques, then biochemical tests like urease, catalase, oxidase. Yes, and apart from that, serology is done, IgG detection. So with the treatment, there will be quadruple or triple therapy. That is generally 2 antibiotics and a proton pump inhibitor is given. Like for example, 2 antibiotics like clarithromycin and metronidazole along with 1 proton pump inhibitor, that is omeprazole. And finally, we have Clostridioides difficile. As the name suggests, it is very difficult to treat this microbe. So it is very hardcore resistant. So again, it is a gram-positive, bacillus, obligate anaerobe, non-spore forming and obligate intracellular. And with respect to pathogenesis, very important, it generates 2 toxins, A and B. A is an enterotoxin, B is a cytotoxin. A1 will damage the intestinal cells and B1 will disrupt this normal cell appearance. The cytoskeleton will be damaged, proton cogenes will be activated, increased cancer risk will be there, and those cancer cells will secrete pro-inflammatory cytokines. Then there are some other risk factors, any gastrointestinal diseases, immunosuppressive states, or older age group. Then with respect to clinical features, GI distress is there, fever is there, pain will be there, and most important, Clostridioides difficile causes pseudomembranous enterocolitis or necrotizing enterocolitis. That is nothing but a false membrane is formed with the infection and inflammation of the colon and intestine, hence the name. With respect to the diagnosis, the sample which we collect is the stool sample. And we do a serology to detect the toxins. And with the molecular methods, ELISA, PCR, MALDI-TOF, colonoscopy is done to observe the pseudomembranes. And with respect to the treatment, generally antibiotics will be there, like vancomycin is there with IV metronidazole, and other option is fidaxomicin, because generally metronidazole is expensive, that is why. And also a fecal transplant can be done. IV immunoglobulin is given because immunocompromised state is a risk factor. And it can be prevented by proper hygiene, like washing the hands, disinfecting the surfaces with 1% hypochlorite, because this also causes hospital outbreaks, Clostridioides difficile. So that is all with the miscellaneous bacterial infections. So thank you so much. We will see in the next lesson.